So, for my Padlet discussion, I found an article about lung cancer. Um, so we have EGFR mutant lung cancer develops resistance to treatment, and we look at the background. So the specific lung cancer is adenocarcinoma. I think one of the limitations of this article is it doesn't really specifically say. It's hard to find which type of cancer cell it is. But it is adenocarcinoma in the lungs. And the main treatment that we're looking at and that is studied and gets resistance built to is osimertinib is the treatment option. It's an oral medication that is very effective, but we're seeing resistance to it. And then also throughout my article, it says a lot of EGFR mutations, which is just another name for lung cancer. It's epidermal growth factor receptor, and the osimertinib is a TKI, which inhibits it basically. It's a tyrosine kinase inhibitor, so it's going to inhibit the mutation, kind of just like pretty much just uncontrolled cell growth. So this is a pivotal study because we're looking at the resistance and kind of looking into future treatment options, which we'll talk about later. So when we look at the actual study, it enrolled 34 patients with these EGFR mutant lung adenocarcinomas. This was a phase 2 clinical trial, and we're evaluating the treatment and the use of local ablative therapy, which we'll see in the next photo, or short for LAT, which is another one of these progressive diseases, another form of this cancer. And what they do is they give them the treatment, and then they'll do a biopsy or surgery later, and they pretty much, then they do some sort of exon or RNA they examine the RNA, and they see where these mutations are, missense, frame shifts, and they kind of just extrapolate from that. As you can kind of see in the bottom right with these pictures, you can see some of these different, mutations and amplifications, especially MET, which inhibits mutation growth. So basically, it's just with that amplifying, there's more growth, more uncontrolled growth, and some of these mechanisms we're looking at, because there's 3 mechanisms at least of resistance. So MET amplification is one of them. We're seeing gene fusions, especially AGK BRAF and MKRN1 BRAF. So these are fusing in patients, which kind of just shows how much this lung cancer is mutating and just how uncontrolled it is. And then another one we have is the KRAS mutations, which is another resistance mechanism, which was observed in 93% of the patients after their second trial, second biopsy or surgery. And if we look at our results here of the experiment, so they took these 34 patients, and after they gave them the treatment option and went back, we can see that osimertinib resistance, there was some sort of mechanism in 93% of the patients. And it was 34 is a pretty good sample size. Now 2 or more of these mechanisms coexisted at once with 73%, and MET amplification was pretty much the highest one for most, which was in 66% of the patients. And we can look at this picture here. So C is like these LAT 001 is just basically one of the patients, and the C is the first run of the trial, and then after the treatment options, we get to the D patients, and you can just see all the different missense. Pretty much all of it is missense mutations. There's some frame shifts at the top, some nonsense mutations, and some you can see the splice sites as well. So just tons of mutations, which is just building resistance to this treatment option. So when you look at some of the potential, now what, how can researchers use this? When we kind of study HIV, we talked about combination therapies and ways to combine medicines to try to slow the evolving process of these mutant diseases. So that's one of the biggest things now is osimertinib is a very new, and it's a very good oral medication, oral inhibitor, but we need to combine that with other stuff, especially MET inhibitors, to slow down this process, because it's going to continue, and although it slows the cancer, it often comes back. And in this article, did a really good job of describing, what's wrong with that. I think the only, like I said, the only limitation or bias is I wish you'd focus a little bit more on like which specific type of cancer. You know, they're all different, and even if you look at here, there's 3 different ones. But overall, yeah, I think what's next is coming up with good combination therapies, similar to what we talked about in HIV, and yeah, that's it.